Hello, I'm glad you could join us today. Welcome to the webinar 2025 Mid-Year Policy Update, the new normal. My name is Angie Fiedler-Sutton, and I use the pronouns she, her. I'm with the National Behavioral Health Association Providers. The National Behavioral Health Association Providers, otherwise known as NBHAP, is a national trade membership association that provides education and advocacy for behavioral health care providers and related entities. We are the leading and unifying voice of addiction-focused treatment programs. We provide membership benefits such as networking and access to compliance information, educational opportunities such as this webinar on our Certificate in Addiction Treatment Marketing, the CATM, and advocacy efforts such as this one to keep those in the industry aware of new laws and regulations that may be coming that will affect them. Working in the behavioral health industry or managing an organization in the industry can be incredibly complex and filled with ever-changing information. NBHAP gives you resources to stay on top of the rules and regulations for your organization to stay compliant. For more information about NBHAP, you can visit our website at www.nbhap.org. And now it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is the founder and principal of Slingshot Solutions, LC, a consulting firm that specializes in behavioral health policy. His clients, past and present, include the International Certification Reciprocity Consortium, I can never say that word, CNRC, the California Consortium of Addiction Programs and Professionals, CCAP, and BHAP. With 20 years of policy experience and over a decade in the behavioral health, Kessler is a fixture in circles that advocate for substance use treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institute on Drug Abuse, NIDA, the Substance Abuse and Mental Health Services Administration, SAMHSA, and other federal actors. Kessler has written legislation and report language adopted by both the House and Senate Appropriations Committee and is presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addictive Disorders, and the College on Problems on Drug Dependence. You can also hear him on the 13th episode of our podcast, Destination Change. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Thank you, Angie, and thank you all for attending. This is actually, I can see by our attendee numbers, one of our stronger attendances, and I can only imagine why. Things are changing rapidly in Washington. Even to say things are changing daily when it comes to health policy and behavioral health policy would be an understatement. They are changing hourly. Case in point, just before I came on to the webinar, the Department of Health and Human Services announced the rescinding of practice guidelines for buprenorphine that were issued in 2021. Why? We don't know. The impact of this, we're not sure. But it's just an example of what we're dealing with in terms of many things being thrown at us at once. As Angie said, I'm Andrew Kessler of Slingshot Solutions. Just a little bit about me that you wouldn't have heard in the bio. I'm not just an advocate. I'm also a huge fan of English soccer and thoroughbred horse racing and a few other things you could see around my office. I'm more than just a face on a screen that works in Washington, D.C., just like all of you are more than just your jobs. We're all very complete people who are dealing with some really challenging times. So, however, for today, for the next 50 minutes or so, it is my job to inform you as to what's going on in Washington and how that could impact what we're doing in behavioral health. The first thing I do have to say is that almost everything I'm going to tell you now is about a situation that is in flux. Please don't take anything I say about anything, any policy, as something that is conclusive, something that is already happened, or a term we're using a lot as a fait accompli. Everything is in flux. A lot of changes have been recommended, proposed. We have a very long way to go before we know exactly what we're going to be dealing with in the future. Just keep that in mind. My goal is usually just to give you, my goal is usually to tell you what's on the horizon. That is an impossible task these days. So what I'm trying to give you right now is a snapshot in time of where we're at. And let's begin. So there is really, for the most part, two major issues that we're following. And it's very confusing to people in Washington. I can't imagine how confusing it is to people outside of Washington. These two processes, what is the future of the Department of Health and Human Services and its funding and its structure? What are the future challenges and changes to Medicaid? Two totally different processes. Were both recommended by the White House in large part? Mostly. Does Congress have a say in all of this? Yes, or at least they're supposed to. So mostly. Get to more of that in a minute. And kind of hovering over both of those is the White House's decision to not focus so much on public health and behavioral health and the work we do, but to instead to have more of a focus on interdiction, justice, arrests, whatever you want to call it. They really have gone heavy on the supply side rhetoric rather than demand side. This is a formula that has not worked in the past. I, in my presentations, try to be very nonpartisan. I hope I can achieve that today. I am presenting to you the facts. I try not to editorialize, even though I have very strong opinions on this. I know everyone has strong opinions about this White House, this Congress. Everything I am about to tell you is factually true as of May 14th, 2025, 1:08 p.m. Eastern Time. Usually in Washington around this time of year, we're playing offense. What I mean by that is we're trying to advance our goals. We're trying to advance legislation. We're trying to advance funding. We're trying to be in a better place than we were last year when it comes to either the creation or expansion of treatment programs, the increased funding of these programs, on and on and on. That is not the case. Since January 21st, the inauguration of President Trump, and before then, really, we're pretty much playing defense. We are in a mode where we're trying to protect what we have. The White House clearly wants to make, and Congress, some members, but not all, clearly wants to make changes that will be detrimental to behavioral health treatment. And as a result, we are trying to protect those programs. And that is taking all our energy. The most valuable resource in Washington is not money. It is not intelligence. It is time. It's really the most valuable resource for anyone who's at a job. How much time do you have to complete your task? We only have so many hours in a day, and we have chose to dedicate that to protecting what we have. Anything else we really don't have time for, because this is taking a massive effort to protect SAMHSA, to protect Medicaid. It's taking quite an effort. Okay, let's start with Medicaid, because that's what's in the news these days. How serious is the threat to Medicaid? Well, the rhetoric you will hear from many in Congress and the majority in Congress is that Medicaid is quote unquote safe. The rhetoric we are hearing, and this isn't on the slide, the slides are just kind of a guide path. Really, you should listen to me rather than just read the slide. Republicans, by and large, have been saying, and NBHAP was on the Hill just 2 weeks ago talking to Republicans and Democrats about this. They want to see Medicaid serve the population it was quote unquote created for. what they call the most vulnerable, the disabled, so on and so forth, which means the real target is the expansion population. Expansion from the ACA. Under the ACA, anyone who was within 133% of the federal poverty line could qualify for Medicaid benefits. Not all, but many Medicaid benefits. The ACA has been in large part a success. The coverage of this expansion population has led to a healthier America and a healthier workforce by all metrics. Many people in both parties are opposed to these Medicaid reforms that are being discussed. Why are Medicaid reforms being discussed? That's the first question. Usually a president in his first term, and always when he has both parties in Congress of his party, what we call the trifecta, House, Senate, President, all governed by one party, the president sees an opportunity to put forth an agenda that will define their 4 years in office. President Biden did it. President Trump attempted to do it in his first term. President Clinton did it. It's nothing new. The reason they go through the reconciliation process is because a reconciliation bill cannot be filibustered. So you just need a simple majority in the Senate. But it's not that easy. When you do the reconciliation process, you have many, 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 many procedural hoops to jump through. And I will not list them all now. What I will say is, very simply, it must be at the very least budget neutral. It cannot add to the deficit. So anything that is spent must be, or proposed to be spent, must be offset. Further, these offsets cannot come from discretionary funding like HHS or labor or commerce or energy, because there's not enough there. They have to come from programs that are spent directly by the Treasury. What are those? Medicare, Medicaid, Social Security, Veterans Benefits, Supplemental Nutrition Assistance Program, what we call SNAP, what other generations may have called food stamps, on and on and on. These are direct expenditures from the Treasury. The House plan to spend to offset $880 billion from the energy and commerce budget, there is no way it can be accomplished without cuts to Medicaid. Several House and Senate members have expressed reservations, and most people think it's moderates. It's not. I don't know why, but Josh Hawley of Missouri, who is one of the most conservative members of the Congress, both fiscally and socially, has said he will not tolerate any cuts to Medicaid. Missouri has a fairly large Medicaid population, I understand. We have talked to members of Congress from California, from Kentucky, from New York, states with large Medicaid populations. And many of these Republicans have given us we want to make sure Medicaid is there for the most vulnerable. And they have said they, quote, won't cut benefits. You can see the air quotes. They won't cut benefits. What they mean when they say this is that they won't cut rates, reimbursement rates. They won't cut what can be covered under Medicaid. What they will do is tinker with who can be covered. Okay? At first, we were wondering if this would mean work requirements. Would this mean a per capita cap, like a set limit per state? Would there be a cut in the federal match, federal funds versus state funds for the expansion states? This is what's being played out. Now, back to my point about things being up to the minute. When I was planning this webinar way back when and preparing for it, I had no idea what point in the process we'd be at. Turns out the House Energy and Commerce Committee just met yesterday to unveil what their plans for Medicaid are. And here is what we know. They have proposed repealing an extra 5% bonus in the American Rescue Plan for expansion states. As many of you know, if a state chose, if you live in a quote expansion state, that state has opted in to the Medicaid expansion for 133% of the federal poverty line population. And they receive X percent from the federal government for each year they're in expansion, which scales downward. So if you were joined in the first year, I think it started at 90%. Then a few years later, I think it went down to 80 and down the line. So when President Biden proposed his American Rescue Plan or his COVID Rescue Plan in 2021, what they did was they put in an extra 5% for states that have chosen to expand, an extra 5% match. This would take that away. It would require budget neutrality for 1115 waivers. This is a big, big deal for those of you who work with criminal justice populations. Many states, I don't have a list in front of me, but many states have taken advantage of Medicaid 1115 waivers and asked for things like coverage for the criminal justice population of Medicaid, coverage up to 90 days pre-release for Medicaid, coverage for peers, on and on and on. 1115 waivers are critical to states being innovative, creative, and putting forth new policies that they think can work to create a healthier population. Medicaid is not supposed to be budget neutral. That's not the point of the program. Okay, but they want budget neutrality in these 1115 waivers, which is almost impossible, which means the states would have to make cuts in their budgets when they submit these waivers. They would mandate a work requirement for the adult population in expansion states. Certain communities, such as those recovering from a natural disaster or incarceration, for example, would get a 90-day waiver. I'm going to give a little bit of editorializing. Someone coming out of prison, finding a job, especially inside 90 days, is not the easiest thing. It's kind of editorial, it's kind of fact. Everyone knows this is true. So just saying you have a 90 days to find work to meet the work requirements, it's a little harsh. There would be other cost sharing, as you see below, for the expansion population that is over 100% of the federal poverty level, from that 100 to 133% of the federal poverty level. Okay. So I'm sorry, I didn't mean to go. I didn't have time to put it in a slide because it just happened yesterday. The impact is the following. Based on estimates, we have seen this could affect between 7 and 8 million people on Medicaid. This could cause a $600 to $700 billion, I don't want to call it a shortfall, but and I don't want to call it savings. This would result in $600 to $700 billion of less Medicaid coverage. I would say by the end of the week, if not early next week, we should start to get information state by state on how this will impact states, because every state is different. Some expansion states have what we call a trigger law, which means if the federal match drops, there goes expansion. I know, for example, North Carolina has a trigger law. I don't know about California. I don't know about Nevada, but certain states have trigger laws. The other question becomes, if that 5% goes away because it was part of the American Rescue Plan and not part of the original ACA, would that trigger the trigger clause? We don't know. We have a lot of analysis to do. So all I can tell you is this. If 7 to 8 million people could lose Medicaid coverage as a result of this plan, there's going to be a fair amount of that population that requires behavioral health services that will not get it. Something like 70% of SUD patients receive some kind of Medicaid in one form or another. I am not a fan of the term of people being, quote, on Medicaid, because that's not how Medicaid works. Some people use Medicaid for all their insurance. In other cases, Medicaid covers things for parts of your health care. For example, between 40 and 50% of all births and neonatal care bill Medicaid in one form or another. Now, does that mean that 40 to 50% of the population is on Medicaid? No, but it plays a role. So this is the current House proposal. Will it pass the House? Remains to be seen. There are moderates who are iffy. There are some moderates who've said it's okay with them. There are conservatives who don't like this. Why? Because they don't think it cuts enough. Statement of fact. Read the news. Representative Chip Roy of Missouri, probably Representative Thomas Massey of Kentucky, they don't think it goes far enough. They want to see more cuts. So, will it pass the Senate? Remains to be seen. Conventional wisdom right now says it's a long shot. Things change every day. So this is where we are right now. This is the House plan. Anything you read or hear that says the cuts to Medicaid aren't that bad or that it doesn't cut benefits is false. Now let's move on to some other drug policy and behavioral health policy coming out of Washington. Every year, the White House is required to submit to Congress by statute a national drug control strategy. In the first year of administration, they don't really have the time. They've only been in office for a few months. It's hard to write a whole strategy. So they're required to submit a statement of priorities. The White House fulfilled this. The deadline is April 1st. It was fulfilled on April 1st, 2025. A statement of drug policy priorities was sent to Capitol Hill. You can see here, there's a lot of emphasis on enforcement, which I have no problem with. Reduce the number of overdose fatalities with a focus on fentanyl, that's great. Secure global supply chain against drug trafficking, great. Stop the flow of drugs across our borders. That's a bit of a red herring. A study by the Cato Institute, which I don't have here, but I'm happy to provide you if you get in touch with me, shows that over 85% of people who are caught crossing the border with fentanyl are American citizens. So is the border a problem? Yes. Are migrants the problem? No. Over 99% of all migrants who cross the border are not found with any narcotics. They want to prevent drug use before it starts. All good. Provide treatment that leads to long-term recovery. Innovative and research data that support drug control strategies. All good. No complaints. Meat and potatoes right down the middle. When we saw this, we said, can't complain. I don't see, maybe I'd like to see one or two things on the workforce. Maybe I'd like to see something about reimbursement, but let's not get greedy. If you were to say these are the priorities and these were to be stuck to, pretty much what you'd expect from any White House, Democrat or Republican. I want you to remember this slide. Remember this slide. Especially that second paragraph, the first paragraph. Bold policy choices employ innovative and sophisticated technology and create a skilled recovery-ready workforce. The administration will strengthen the nation's peer support services and workforce. And I want you to remember that last slide about fighting fentanyl overdoses. All right, put that in your head. We're going to come back to that. In late March, the White House did what we call a clawback of unspent funds. Earlier, I mentioned the American Rescue Plan passed under President Biden in 2021. And as we all know, during the COVID emergency, overdose rates, alcoholism, depression were going through the roof. And the White House and Congress both thought that SAMHSA needed a boost to deal with these. They were correct. SAMHSA was told they had until September 30th, 2025 to spend these funds. CDC, same thing. Now, CDC's money was a little more about infrastructure, respirators, COVID tests, vaccines. It was more about COVID itself. The SAMHSA funding was more for the impact of the pandemic, what people were feeling and going through. The White House said, anything unspent at this point, give it back. Most, if not all, legal scholars agree this is not legal because once funds have been appropriated by Congress, only Congress can take them back. The Trump White House and its legal advisors are under the impression that Nixon versus the United States was incorrectly decided in 1973. What was that? That was a Supreme Court case concerning impoundment. President Nixon thought he had the power to take funds appropriated by Congress and not spend them. The Supreme Court said you are incorrect. You do not have that power. It is the plan of the Trump administration to challenge this decision. This is all setting up that challenge. The White House said, we are freezing the money. The courts have said, no, you're not. A legal battle continues between the federal courts and the White House. About $1.3 billion of the SAMHSA money was frozen. Has it since started to go back out? Some stories, some grants we hear yes, some grants we hear no. Now, if you want to argue to me that because the COVID emergency is over, which is the rationale of the White House, we no longer need this money, you could probably make a decent case to me that the need for more respirators, the need for more COVID tests, what have you, is not as necessary as it was 5 years ago. In a vacuum, I agree with you. Personally, I'm a public health advocate. I see no harm in being a little more prepared. But I can understand that. But just because the pandemic is over, that does not mean that people with behavioral health disorders, as a result of the pandemic, are automatically better. People who developed alcoholism, substance use disorders, depression, had to deal with suicide attempts, on and on and on, they still may require assistance. So the logic that the emergency is over, and therefore we don't need behavioral health funding to deal with the emergency, kind of falls flat because people are still very much dealing with the effects of the pandemic at a behavioral health level. Courts have said that the clawback is not legal, as I said, and more decisions are certainly forthcoming. There have been many legal challenges to many actions like this by the Trump administration, and one of them will make their way to the Supreme Court. And the Supreme Court will then make its decision as to whether Nixon versus the United States is still good law. And we'll have to wait for that day. In addition to these clawbacks, we are all familiar now with layoffs that have been happening at HHS. In DC, we call them RIFs, R-I-F, reductions in force. The White House has been dismissing federal employees left and right in an effort to shrink the size of the federal workforce. There were rumors, and again, only rumors, that SAMHSA could see a reduction in workforce of about 50%. This has not come to pass yet. So far, based on best estimates, the workforce is down between 17 and 22%. I find this odd. Again, this is a statement of fact. One of the first things Secretary Kennedy did when he took office as Secretary of Health and Human Services was to reissue a public health emergency on opioids and overdose. So the public health emergency remains in place. This White House and its secretary have said on the record, this remains a public health emergency, which would allow this White House, if they so chose, and Congress to ease regulations and secure additional funding to deal with the crisis. Where I have to editorialize, or at least just ask the question, is if this White House is on the record as saying that this is a public health emergency, why are we cutting the workforce at SAMHSA and CDC and NIH, all of which contribute to the well-being of people with behavioral health disorders? It's not making a lot of sense to me. At the Substance Use and Mental Health Service Administration, the Legislative Affairs Team, the National Mental Health Substance Use Policy Lab, the Office of Minority Health, Center for Behavioral Health Statistics, and the National Survey on Drug Use and Health, which surveys 70,000 households a year and is the preeminent data point we have on drug use in this country. The entire staff for all these offices have been riffed. A few were brought back. Also, people who were in their probationary status working for these offices, which means less than 1 year, were riffed. At the Center for Mental Health Services, almost the entire Office of the Director, the Office of Community Supports, and the Division of Contracts Management, all riffed. At the Center for Disease Control, the Office of Smoking Health, very much an issue in behavioral health, the Division of Population Health, the Excessive Alcohol Use Prevention Program, and you can see others. Those of us who work in behavioral health, you may not know it, but you do benefit from these programs. They produce the data that we rely so heavily on when dealing with population health. Now we get to probably the bulk of the issues we're dealing with. On March 27th, HHS Secretary Robert Kennedy announced a major reorganization of SUD and the creation of the Administration for a Healthy America, which will combine multiple agencies, as you can see below, including SAMHSA, into a unified entity. Their thinking is that in getting rid of all the communications offices and legislative offices of all these agencies and putting them under one roof, it will be, quote, more efficient. The federal government, in the president's skinny budget, the White House, has asked Congress for $500 million to create this new agency. That's $500 million that won't be spent on public health. It'll just go towards creating this agency. If you think that's efficient, please explain it to me. Trying not to editorialize, but anyone who says we need to spend $500 million to take all these programs that already exist so we can make them more efficient, I don't see how that adds up. So we have taken to calling this new Administration for a Healthy America, which does not exist yet, because by law, the executive cannot create a new agency. Only Congress can, especially if it is to receive congressional appropriations. Think back to 2001, 2002, when the Department of Homeland Security was created. The president proposed it. Congress wrote the legislation. Congress created the agency. The president signed the law. Congress created appropriations. The president signed that law. And we have a new agency. That's how statute says it needs to work. This White House is insistent that they can create this agency without congressional input. Remains to be seen who is going to win that power struggle. Not many Republicans in Congress have pushed back on this, at least publicly. With this White House, many members of Congress are choosing to what we call back channel, making their thoughts known outside of the public eye and not in the press. So this would basically mean SAMHSA wouldn't exist. Would the block grant still exist? Well, we'll get to that. Secretary Kennedy, in his testimony this morning before the House Appropriations Committee, said, we're not shuttering SAMHSA, we're moving SAMHSA. But what he didn't mention was many of the programs at SAMHSA are slated for elimination. Under AHA, and if you're a child of the 80s like I am, you're laughing hysterically at this slide. If you're not, you're saying, Andrew, what are you talking about? In the early days of MTV, there was a Norwegian band named AHA, and they made one of the landmark videos that combined live action and animation, and it's become one of the most famous pop culture touch points for children of the 80s. So anyway, according to Secretary Kennedy, this centralization will improve coordination. Secretary Kennedy was asked this morning, was this studied? Can you point to a study that said this will improve efficiency? He could not. Statement of fact. AHA would be divided into the following divisions. You can see what your eyes are probably drawn to is mental health. Those of you who work in mental health are probably saying, okay, that's good. Those of you who work in SUD are probably saying, where's SUD? And I think you know the answer. The answer is it would be, quote, under mental health. As someone who's worked on SUD policy, I can tell you that's a losing proposition from the jump. People who consider SUD a subset of mental health don't understand SUD. Now, do SUD and mental health co-occur quite often? Of course they do. But when it comes to dollars for programs, if you give it to mental health and you say it's for mental health and SUD, then the two have to fight for those funds. And we don't want that. We want SUD to have dedicated funding. We want mental health to have dedicated funding. We want co-occurring orders to have dedicated funding. SUD is not a subset of mental health, and labeling it as such is detrimental to our narrative. As I said, can they just do this? Technically, no. Secretary Kennedy has been asked about these plans. He's given his response as saying it will be more efficient. That's what they're saying. I didn't update this slide because it just happened 3 days ago. I said when I wrote these slides, no lawsuits have been filed. That is no longer accurate. On Friday, just 4 days ago, 3 days ago, whenever it was, a lawsuit was filed by 20 states' attorneys general challenging this reorganization. So now that's in court. The judge has not ruled yet. As far as we know, some mechanisms from SAMHSA will stay intact. Some will not. Usually, by this time, what we have from the White House is a plan for next year's budget and appropriations. This is discretionary spending, has nothing to do with Medicare and Medicaid, has to do with spending programs at HHS, Commerce, Energy, Labor, all the departments, Pentagon. Usually by this time, we have that from the White House. In a new administration, it takes a little longer. Memorial Day is pushing it. And usually what a new administration does is, because they know it'll take a while to get their budget to Capitol Hill, is they issue a skinny budget. Okay. During this skinny budget, or during the creation of a budget, there's a very, very long process. Now, I'm going back further than the 80s. I'm going back into the early 60s. I was not alive, but another famous movie. If anyone can put in the chat what movie they know this is. Yes. Angie, I thought it was a participant. You're not supposed to. This is from The Music Man. And he is singing in this scene, "You've got trouble, my friend," because a pool hall just opened. And the character, played by Robert Preston, is saying, "You've got trouble with a capital T," and that rhymes with P, and that stands for pool. Well, in this case, our trouble with a capital T that rhymes with P stands for passback. And you're thinking to yourself, what the heck is a passback? Well, you're going to learn something new today. A passback is exactly what it sounds like. It's not tricky. The White House Office of Management and Budget and each executive agency, HHS, Energy, Labor, Justice, will send documents back and forth on their budget. OMB at the White House will say, here's what we propose. Here's how much you have to spend. And then an agency like HHS will get it, look it over, and say, this is how we're going to spend it. Send it back. OMB will say, okay, here's what we think you should change. And the document will go back and forth. It's called a passback. Last month, a passback between OMB and HHS was leaked. To give you an idea of how shocking this was, I've been in Washington for 30 years. I've been doing this work for 24 years. Never seen a passback leaked. Why? Because they're boring. All passbacks usually do is mark a moment in time. When you say, hey, where are we at with the passback? You're like, okay, HHS got their passback. OMB got their passback. It's just letting you know they're close. Things are starting to happen. The question has never been about amounts. The question has always been, where in the process are we? That's it. That all changed. Okay? Because this passback document laid out the reorganization plan I was just talking about, where SAMHSA and HRSA and other agencies would cease to exist. They'd be under this AHA. Okay? Now, the good news, if you can call it that, is state block grants for SUD and mental health. They are still there. My biggest concern when I read about this reorganization was the block grant. No lie. I was like, what's going to happen to the block grant? Concern number one literally kept me up at night. I'm not exaggerating. The state opioid response grant, that stays. For those of you who work in mental health and on suicide prevention, 988 hotline funding, Garrett Lee Smith funding for suicide prevention, that stays. That's about it. Just about every other discretionary grant at SAMHSA is done away with. Because in the opinion of the White House and Mr. Kennedy, based on his testimony today, statement of fact, they're quote unquote duplicative of the block grant. This is incorrect. The block grant has statutory guidelines on what it could be spent on. These discretionary programs are spent on things that the block grant cannot be spent on. For example, the purchasing of naloxone, community investment for recovery, on and on and on. Peer workforce. These are the recommended cuts. Remember that slide I said, remember, about the president's priorities? One of their top priorities, eliminate overdoses. Naloxone grants from SAMHSA, recommended elimination. First responder training for naloxone grants, recommended elimination. Recovery, building communities of recovery, grants for pregnant and postpartum women, emergency department alternatives to opioids, treatment systems for the homeless. None of these, none, can be addressed by the block grant. And all of these discretionary grants are proposed for elimination by the president's skinny budget. Again, this is a snapshot in time. This is not done and dusted. Congress gets to have their say. What they say is anybody's guess. But this is what the White House has proposed. So on the one hand, to give you an idea of the chaos we are dealing with in Washington, and I know people like to make fun of Washington and say it's always like this, it's always crazy and chaotic. Yeah, maybe a little bit. This is breaking new ground. I have a document from the White House submitted to Congress saying one of their top priorities is overdose prevention. I have another document from the White House saying one of their priorities is eliminating naloxone grants. What am I supposed to do with this information? That is how confusing things are in Washington right now when it comes to policy making. It's 1:47. I usually try and stop around 1:45, so I'm 2 minutes over. And now is when I like to open it up for questions. I like to think that you don't have any, but because I'm so comprehensive, but I'm sure you do. If you don't, that's fine. I'm not forcing you to think of any. But if you want to put it in the chat, I haven't been able to read the chat this whole time because I've had my screen in front of me. If you want to put it in the chat or however Angie wants to moderate it, I'm happy to answer questions for the next few minutes.
Not much on the chat. Please keep your questions to his presentation. But if you have any questions about what he's presented, and Andrew, you can't give me, a theater nerd, a question about a musical theater and not expect me to answer.
Sorry.
I was a theater minor in college. I spent 20 years volunteering for a magazine in Kansas City.
I myself minored in drama and dramatic literature, so I was more on the playwriting side. But the Music Man is a classic. So.
Oh no, the Simpsons parody version of it.
Absolutely.
With Troy McClure.
Yeah.
No, it wasn't Troy. But it was Phil Hartman.
Yeah. Tina, I'd like to answer your, in terms of your ignoring the Constitution question, I may be a lawyer, but I'm not a constitutional scholar. I'm going to leave that to the courts. But your comment about the deaf and illiterate is poignant because I don't want anyone to think, and you probably don't, that the behavioral health community is taking this on alone. We have allies. And the leading ally is the disability community. I only gave you a presentation as it pertains to behavioral health. One of the agencies that is slated for folding, elimination, whatever term of art they want to use, is HRSA, the Health Resource Services Administration, which is responsible in large part for a lot of the safety net programs, federally qualified health centers among them. The disability community is very, very disturbed by the proposed elimination of HRSA. They were actually first out the gate. When this leaked, by the end of the day, over 450 disability communities had signed on to a letter, organizations had signed on to a letter protesting this. Much remains to be seen about what Congress is willing to do. Based on what I have heard and what I can look into the future, whether the House follows these guidelines of the president's budget in their appropriations remains to be seen. There are many members of the House who would like to see a lot of this come to fruition. The Senate is much, much trickier. The Senate, this is a major, major, major restructuring of government. And there are many senators, whether they agree with President Trump or not in theory, and in policy, don't like being sidelined. No one becomes a U.S. senator so they can be ignored. Let me tell you that. Many senators are saying, wait a minute, this is our job. And if you think you can, with the stroke of a pen, change how government works, we're going to have something to say about that. So we will see. Oh, CCBHC. Yes, Patricia. Your question, do we know where CCBHC funding and grants landed in the skinny budget? Yes, we do. Not well. There was actually some misinterpretation. CCBHC grants, about $385 million worth at SAMHSA, were proposed for elimination in the skinny budget. This did not mean, a lot of people took this to mean CCBHCs would go away. It's not what it means. CCBHCs will continue to exist to build Medicaid, what have you. What it really impacts is the expansion of CCBHCs, new CCBHCs, letting them get set up and on their feet. That's what it would impact. What I'm concerned about when it comes to CCBHCs is the two authors of the CCBHC legislation who always looked out for its funding, Roy Blunt, Republican of Missouri, and Debbie Stabenow, Democrat of Michigan. Roy Blunt has retired, and Debbie Stabenow has retired. So their champions aren't there anymore. Some of their House champions are still there, but their Senate champions aren't. So it's a tougher task this time around. So we'll see. CCBHCs are very much the expansion and the CCBHC model in terms of moving forward is at risk as a result of this proposal. Yes.
Any other questions related to his presentation? Okay. I want to thank Andrew Kessler for presenting today. Thanks as well to you for participating. Did you know that NBHAP members get an advocacy update from Andrew on a monthly basis? Members also get access to our legal repository and our state frequently asked questions. You can find out more about our benefits on our website. We hope you join us for future BHAP webinars. You can sign up for our various newsletters, which includes emails specific to upcoming events at our website, www.nbhap.org. With that, this concludes today's webinar. Thanks today.